Today, we are going to tackle a very high-yield topic, and one that often causes a lot of confusion: inflammatory bowel disease. Now, my promise to you is very simple. By the time we finish this session, you will be able to tell the difference between ulcerative colitis and Crohn's disease with full confidence. Cello, let's start. So picture this. This is the exact scenario you're going to face, both in your exams and in your clinics. A patient comes to you with chronic diarrhea, abdominal pain, and the big question in your mind is, what am I dealing with here? Is it ulcerative colitis or is it Crohn's disease? Together, let's figure out how to solve this puzzle. Here is our game plan for today. First, we'll understand the single most important core concept. Get that right and everything else falls into place. Then we'll look at the clinical picture, investigations, management, and the risk of malignancy. Finally, a super quick revision for your exams. So stick with me and I guarantee you'll master this. Let's begin with the foundation, the core concept. Okay, first things first, we absolutely must understand the fundamental difference. If you get this one slide right, trust me, the rest of the topic becomes very, very easy. This is the heart of the matter. So what is the key point here? Think of ulcerative colitis like this. It's a continuous sheet of inflammation. It starts in the rectum and moves upwards continuously, like a carpet. And it's only on the surface. It's superficial, just involving the mucosa and submucosa. And where is it? Only in the colon and rectum. That's it. Crohn's, on the other hand, is completely different. It has skip lesions, meaning you have a patch of disease, then normal bowel, then another patch of disease. It's patchy, and it's deep or transmural, meaning the inflammation goes through the entire wall of the bowel. And it can happen anywhere, literally from the mouth to the anus. So remember this funda. UC is continuous and superficial. Crohn's is patchy and deep. Now let's see how this basic difference, superficial versus deep inflammation, directly affects how the patient presents to you. What will their complaints be? How will you know just from listening to their story? See, everything flows from that core concept. In UC, because the inflammation is superficial and limited to the colon, the #1 symptom is painless bleeding from the rectum with bloody diarrhea. But in Crohn's, because the inflammation is deep and often in the small bowel, the patient will complain of pain, typically in the right lower quadrant, and signs of malabsorption, like weight loss. And think about it. Because the inflammation in Crohn's is transmural, it can create tunnels, fistulas, or cause scarring that leads to blockages or strictures. These are very rare in UC. Every single point on this table is a potential MCQ, so please pay close attention. Okay, so the patient has given you the history. Now, you need to confirm your diagnosis. What are the key findings in our investigations that will point us to the right answer? Let's have a look. When you do an endoscopy, the difference is just night and day. In ulcerative colitis, you'll see this continuous redness. The surface looks like velvet, and you can't see the normal blood vessels anymore. We say the mucosa is friable, meaning it bleeds with the slightest touch. In Crohn's disease, you'll see the classic cobblestone pattern. Why? Because you have these deep, long, snake-like ulcers that cut through the mucosa, leaving islands of normal tissue in between, just like a cobblestone street. Again, you can see how superficial versus deep inflammation explains everything. And here are the classic radiology findings from a barium study. These are very famous signs. On the left, for UC, this chronic inflammation makes the colon lose all its normal folds, what we call haustrations. So it just becomes a smooth, featureless tube, a lead pipe. On the right, for Crohn's, that deep transmural inflammation causes so much scarring and thickening of the wall that the lumen becomes extremely narrow. It looks just like a thin piece of string, the famous string sign of Cantor. Two very distinct, very high-yield signs to remember. Now let's talk about blood tests, or serology. Now these aren't used to make the final diagnosis, but they are very strong associations that examiners love to ask about. P-ANCA is positive in ulcerative colitis, and ASCA is positive in Crohn's disease. A simple way to remember this for your Viva is PUC. P for P-ANCA and UC for ulcerative colitis. Simple? No? Very important point now. Please remember, IBD is not just a disease of the gut. It is a systemic illness. The inflammation can pop up anywhere in the body. The patient might complain of joint pain, painful skin ulcers like pyoderma gangrenosum, or red, painful eyes due to uveitis. And here is a 5-star association you absolutely must know: primary sclerosing cholangitis, or PSC, a disease of the bile ducts, is very strongly linked with ulcerative colitis. Always keep an eye out for these extraintestinal signs. Sometimes they are the very first clue. Right, we've made our diagnosis. So what's next? Management.
The treatment strategy is quite different for UC and Crohn's, so let's break it down properly.
For ulcerative colitis, we follow a step-up approach. It's very logical. We start simple. For mild disease, a 5-ASA drug like mesalamine is enough. If the patient is not improving, we step up. We add oral steroids. If the disease is very severe, the patient must be admitted for IV steroids. And if even that doesn't work, or the patient becomes dependent on steroids, then we bring out the heavy artillery, biologics or immunomodulators. It's like climbing a ladder, based on how sick the patient is. Now, the thinking for Crohn's management is a little different. We think in 2 phases. Phase 1 is induction of remission. Our goal is to put out the fire, to make the patient better quickly. For this, we use steroids. Phase 2 is maintenance of remission. Once the fire is out, we need to keep it out, and for this, we use drugs like azathioprine or biologics. A very crucial point to note here is that 5-SA drugs, which are the backbone of UC treatment, are generally not effective for maintaining remission in Crohn's disease.
Let's move to a very serious and important topic, the long-term risk of cancer or malignancy. This is extremely important, not just for your exams, but for counseling your patients in the future. Now, the types of cancer are different for each disease. In Crohn's disease, the chronic systemic inflammation and the use of certain drugs can increase the risk of blood cancers, like lymphoma. In ulcerative colitis, remember that strong association with PSC? That chronic inflammation in the bile ducts leads to a much higher risk of cholangiocarcinoma, which is cancer of the bile duct. Both diseases, of course, increase the risk of colorectal cancer, but listen carefully. IBD-related cancer is a different beast altogether. It happens much earlier, 10 to 15 years younger than regular colon cancer. And the genetic pathway is different. It doesn't follow the usual adenoma-carcinoma sequence. Instead, it follows an inflammation-dysplasia-carcinoma pathway. What does that mean? It means the chronic inflammation itself drives the cells to become abnormal or dysplastic, which is a precancerous stage. This is exactly why these patients need regular colonoscopies to screen for this dysplasia before it becomes cancer.
All right, we have covered a lot of ground. Let's put it all together now in one final summary. This is the slide you will want to take a screenshot of for your last-minute revision before the exam.
So here it is, the ultimate cheat sheet. You see continuous, superficial, colon, and rectum only. You see a lead pipe on radiology, it's PNCA positive, and very important, surgery is curative. If you remove the colon, the disease is gone. Crohn's, skip lesions, transmural, mouth to anus. You see cobblestoning and the string sign. It's ASCA positive, and surgery is not curative because the disease can recur anywhere in the remaining bowel. If you remember this table, you can tackle almost any question on this topic.
And I'll leave you with a final clinical question to think about. Between a skin lesion like pyoderma and an eye problem like uveitis, which one is more dangerous for the patient? Think about it. It's uveitis. Why? Because it can lead to permanent loss of vision. It's a powerful reminder that these are systemic diseases with very serious consequences. Master these differences and you will do very well. Thank you and all the best for your exam.